Start tayo. So, our topic today is about infective endocarditis. Okay? Kahit parang mahaba yung chapter sa book, pero sa exam baka mga tatlong questions lang. So, bilisan natin. Infective endocarditis is infection of the, it involves the myocardium. Ang prototype na lesion niya is vegetation. May nakikita kaming mass sa 2D echo na nakadikit either sa valve or for example, kung meron siyang ventricular septal defect, nandun ka-attach na parang nag-move na mass. Nakikita namin yan and it helped distinguishing characteristics onto the echo na nalalaman namin vegetation siya versus a thrombus formation. I don't know kung tulong pa sa inyo, but it involves the location. For example, if there is a mass on the mitral valve, pag nandun siya sa left ventricular side, baka tumor yan. Pero pag nandun siya sa left atrial side, it's either a thrombus or vegetations. So kung ang patient, ang mass niya ay it galing sa may left atrial appendage, baka thrombus yun. Pero kung nandun lang siya sa mismo sa valve naka-attach, most likely vegetation yun. And may characteristic din kami nakikita sa 2D echo. Pag vegetation kasi, homogeneous siya, meaning pare-parehas yung kulay. Pero pag thrombus, may mga spots na whiter, may area naman na medyo lighter yung color. So, thrombus yun. Okay? Pag yung infection does not involve inside the heart, let's say, nasa artery, let's say you have a patent ductus arteriosus, tas meron doong infection na nakikita, or in the coarctation of aorta, or kahit saan na artery, if that artery is infected, we call it infective endarteritis. Pero pag ng myocardium, we call it infective endocarditis. So we classify it according to temporal evolution. Minsan acute, minsan subacute. Pag acute, less than 1 week. Pag subacute, more than a week to 6 weeks. Ganun. The site of infection, of course, you have to identify kung sa mitral valve, tricuspid valve, because there are clinical conditions na pag tricuspid valve ang involved, kailangan mong tanungin, baka IV drug user yan. Mga ganun ba? Pag sa left side naman, kahit naman IV drug user, but it will help you kasi there are common bacteria na pag IV drug user, if it's the right side, for example, staph yun, pero think of other cause rather than staph. So, importante din yung site of location, a site of infection. And then the cause of infection. What type of bacteria infects? Is it coagulase negative staph or coagulase negative mga ganun, or Staphylococcus aureus, Streptococcus viridans, mga ganun, Hasik group ba to, or Pseudomonas? Because pag Pseudomonas yun, nakakaloka yun. Parang let us pray to God na lang. Kasi, di ba parang nakakatakot si Pseudomonas kaysa sa COVID-19? So predisposing risk factors, you have to identify that. IV drug user ba? Meron bang congenital defect? Meron bang inserted na intracardiac device, a pacemaker, an implantable cardio defibrillator, mga ganon. Or meron ba siyang recent surgery sa heart, let's say mitral valve replacement or aortic valve replacement, kasi it will help you kung nagkaroon siya ng fever, baka infected yung nilagay na valve. So, acute versus subacute. Pag acute, ayun, less than 1 week. And then most commonly, there will be fever. Tapos, subacute, indolent na yung course niya. Meaning, pag subacute, baka meron na mga associated like weight loss, mga ganun. Kasi medyo matagal-tagal na siya. But still, the patient will have fever. And pag subacute, it can now has a high risk to metastasize, meaning yung vegetation nag-emboli and then will go to, let's say, cerebral artery and then infect the cerebral artery. Ang tawag na nun is endarteritis, di ba? So, pwede siyang, because of infection of that artery will be aneurysmal and then bleed. So, meron akong patient na ganun, presented as cerebral hemorrhage. Yun pala, may vegetation. So, Pwedeng ganyan. Ayun. Okay. So, this is about 2.6. Ganun ka-common. Wait lang ha. Kailangan kong tanggalin yung face nyo. So, about 2.6 to 7 per 100,000, hindi siya ganun ka-common. Patapos pag-develop versus developing country, magkaiba din yung cost. Kasi pag developed countries, more on IV drug users or becoming elderly. Pero pag developing countries, ito yung mga rheumatic heart disease, ang possible cause. Kasi pwede ka namang may mitral stenosis from rheumatic heart disease. Tapos nag-vegetation. So it's a predisposing factor for an infective endocarditis. Okay? Meron tayong tinatawag na native valve versus prosthetic valve. Pag sinabi natin native valve, the valve involved is yung native, charot. So, yung mitral valve, tricuspid valve, pulmonic valve, aortic valve na hindi pa nilalagyan ng mechanical. So, meron naman tayong tinatawag na prosthetic valve. It can either be a bioprosthetic valve or mechanical valve. So, if that prosthetic valve is involved, we call it prosthetic valve endocarditis. Okay? Okay. So, pag prosthetic valve, it's about 30%. Pag native valve, it's about 35%. Okay? Pag prosthetic valve, usually within 2 months after surgery. So, pag mangyari yan within 2 months, ibig sabihin, nakakatakot yan. Kasi ang valve is, ang bioprosthetic valve or metallic valve is like, ano ba, 300,000 to 500,000 pa lang. But surgery, you will spend like 1M for that. And it has been infected kasi hindi malinis yung pagkakahawak doon sa operating room, hindi siya sterile kaya na-infect yung valve. So pag valve surgery talagang sobra kaming strict sa sterility kasi we don't want the valve to be infected. Okay? Pag more than 12 months nagkaroon ng infection yung prosthetic valve, ibig sabihin hindi na yan, most likely hindi na yan intraoperatively or nosocomial. Parang nakuha na niya sa labas. Okay? Predisposing factors, if there is a congenital heart disease like PDA or defect, ASD, they are a high risk of endocarditis. Rheumatic heart disease, illicit IV drug user, degenerative valve disease, let's say aortic valve stenosis from calcifications because of aging, or ito increasing to ngayon, yung intracardiac devices because mas marami na yung nakaka-afford maglagay ng pacemaker or ICD and the risk for infection is now increasing. Okay. Pag merong oral cavity, kaya history yung may dental caries or may mga skin lesions, these are high risk or predisposing factors for infective endocarditis or any upper respiratory tract infection. Now, hindi to lalabas sa exam nyo ngayon, but in board exam, lumalabas yung HASIC group kasi most of the time, pag negative yung blood group, HASIC group yun. So, kailangan nyo siyang i-memorize yung HACA key. So, K, Haemophilus, Actinobacillus, Cardiobacterium, Echinella, Kingella. Ganon. Memorize nyo yun, ha? Okay. Wait lang. Common mistake, yung Actinobacillus is now Aggregatibacter. So, baka, magkamali kayo. They are just the same. Pinalitan lang na naging Aggregatibacter. So, dapat nilagay ko na dyan Aggregatibacter. Kasi yun na yung minimemorize nyo. Sa board exam nyo, baka Aggregatibacter na ang gamitin. Hindi na Actinobacillus. Okay, pwede din Streptococcus, Galolyticus, Enterococci, maraming possible causes. So, pag native valve, it can either be healthcare associated or community acquired. Ibig sabihin ng healthcare, nakuha na yung bacteria nang na-hospital siya. Pag community acquired, doon yung nakuha sa labas. Sa bahay nila, for example, or kahit saan, doon yung nakuha yung bacteria. So either healthcare associated or community-acquired, pag native valve involvement, the most common bacteria is Staphylococcus aureus. Okay? So, yun ang tatandaan niyo. Staphylococcus aureus pa rin. And, pag tatanungin kayo, what is the most common organism involved? If you answer staph, you have increased your probability to 70%. So, kung ako sa mga students, staph palagi ang isasagot ko. Okay? Now, prosthetic valve, ito yung medyo magme-memorize ka because if it's less than 1 year or 12 months, mga 6 to 12 months, the most common organism involved is coagulase negative. Okay? But after 1 year, staph na ulit. So, ito yung mga may memorize yung naiiba kasi halos lahat staph. And then pag prosthetic valve endocarditis, coagulase negative staph. Okay? So, pag more than 12 months, baka na prosthetic valve involvement, baka parehas na siya yung community-acquired native valve involvement, endocarditis. Meaning, the most common organism involved is now staph. But if it's less than 12 months, 2 to 12 months, the most common cause is coagulase negative staph. But either more than 12 months or less than 12 months pa yan, as long as it's a prosthetic valve endocarditis, that bacteria is resistant to methicillin. Importante yun. Because if it's a prosthetic valve, hindi lang ang management mo like ceftriaxone lang. Dadagdagan mo siya ng drugs for consideration of a resistance to methicillin. Let's say you add vancomycin, mga ganun. So, ulitin ko lang, pag less than 12 months, the most common cause is coagulase negative staph. Pag more than 12 months, staph ang most common. But either of the two, as long as it's a prosthetic valve involvement, you have to consider that it is resistant to methicillin. So you have to give medications for resistant methicillin na bacteria. Let's say you add vancomycin. Okay. Pag nilagyan ng pacemaker or defibrillator, either or coagulase negative, halos sila magkaparehas. You have a table in Harrison, mas common yung coagulase by a number, parang ganon. Pero on description, parehas lang sila. So either the two, staph or coagulase negative, parehas sila, lalaban lang sila. But both of them are resistant to methicillin. So take note, if there is like a prosthetic valve or any device implanted and that has been infected, you have to add medications for resistance to methicillin. So you add vancomycin. Okay. Pag endocarditis among IV drug users then, the most common valve involved is Staphylococcus aureus. Pag if it's a left-sided valve, you have to consider other causes like Pseudomonas, Candida species. Kasi pag IV drug users, the most common valve involved is the right side or tricuspid valve. And the most common etiology still is Staphylococcus aureus. But if the patient is an IV drug user, either tricuspid valve or mitral valve ang involved, that organism is resistant to methicillin. So we have to add vancomycin. Okay. So 5 to 15% can have a negative blood culture, and it's because of Hasik organism, Coxiella, Bartonella, granulic cheme, mga ganong mahirap. So ang common answer dyan is Hasik group. But of course, minsan Coxiella din ang lumalabas na answer. So magaling naman kayo mag-memory. But only 5 to 15% yung negative blood culture. Most of the time, we have a positive blood culture if it's an infective endocarditis. Kasi nga, mas septic yung organism. I mean, nagkakaroon ng sepsis yung pasyente. So, the high yield for a positive blood culture is high. Okay. So, the endothelium is protected naman. Hindi naman siya madali-daling magkaroon ng except if there are now conditions that aggravates or causes Let's say there is a mitral regurgitation or the patient has ventricular septal defect kasi nagkakaroon na ng turbulence. So these murmurs causes there's turbulence of flow, it damages the endothelium and will cause damage to the endothelium. Tas yung bacteria will set in and cause vegetation. Minsan, non-bacterial thrombotic endocarditis siya. So ano naman to? Walang organism. Kasi ang vegetation is made up of the organism. Tapos nag-form siya ng capsule, may mga platelet keme, and then kaya siya vegetation. And then hindi siya masyadong na penetrate ng antibiotic because it's encapsulated. Kaya napakahirap i-manage ng vegetation. So sometimes what we call as vegetation is negative bacteria inside. So ang tawag nun is non-bacterial thrombotic endocarditis. Yun pala, it's only because of platelet fibrin thrombus formation. So these are commonly seen in patients na, let's say, may mga valve involvement, yung may mga mitral regurgitation, aortic stenosis, aortic regurgitation, mga ganon. But if the non-bacterial thrombotic endocarditis is it is seen in patients with malignancy or chronic disease or SLA, ang tawag nun is marantic endocarditis, not infective endocarditis. Kasi wala siyang infection. So we call it marantic endocarditis. Okay? Sa 2D echo, mahirapan din naman kaming mag-differentiate if it's a non-bacterial versus a vegetation. So you have to just describe it as a mass in the mitral valve, on the left atrial side, something like that, and then correlate clinically. So ikaw na yung doktor na humahawak yan, and wala namang tingin mo wala namang infection, and then the patient has systemic lupus erythematosus, baka marantic endocarditis yan. Okay? So the most common manifestations is fever, but patients can have chills, anorexia, myalgias, back pain, and meron kang tinatawag na new onset murmur. Ang mahirap lang, pag hindi mo patient siya before and then may narinig kang murmur, yun yung mahirap kasi baka matagal na siyang may murmur. But if patient mo siya, na bagong patient, and then you have heard a murmur, then the yield or the risk for IA is now high. Okay? There can be splenomegaly, tapos mga Osler's nose, Janeway lesion. So we will talk about that. Laboratories, of course, there is leukocytosis, anemia can happen, elevated erythrocyte sedimentation rate, and C-reactive protein, which are indications of inflammatory process. Okay? So, kung Jones criteria ang pag-diagnose ng rheumatic heart disease, huwag mako-confuse. Common mistake yan among students. Pati nga kaming consultants din, medyo napapagpalit namin. Jukes criteria naman sa infective endocarditis. So, you need 2 major or 1 major plus 3 minor or 5 minor. In other books, pag wala daw major, 5 minor lang, you have to think, parang baka pilit lang na ginawa lang 5 minor. So, most of the time, you still have at least 1 major pa rin. So, ano yung major criteria? Yung either a positive blood culture or 2D echo. So, most of the time, you have 1. Kasi pag negative yung blood culture because of, let's say, HASIC group, sa 2D echo, most likely may makikita ka. So, at least you have 1 major criteria, and you just have to look for 3 minor criteria, and then mataas na yung yield na correct yung diagnosis niyo. So, sa positive blood culture, eto yung mga organisms na involved. Kasi baka naman ibang organism, not in this list, hindi siya magiging major kahit nag-positive blood culture. So, this includes Berigans streptococci, Streptococcus galolyticus, the HASIC group, Staphylococcus aureus, or Enterococci. Tapos, pwede ding Coxiella burnetii, or kahit wala kang positive blood culture, but there is a phase 1 IgG antibody titer of more than 1:800, another major criteria na yun. But wala tayong ganyan dito sa Tacloban. I think it's on higher center lang. Now, onto the echo, you can see a vegetation, may nakikita kaming, kunwari yung prosthetic valve, minsan walang vegetation, pero na-detach na siya. Parang we call it oscillating movement of the prosthetic valve, or there is, ano siya, rocking motion, ang term namin yan. Meaning, every contraction na nahihiwalay siya kasi nga yung tinatahi kasi yung valve na yan, and then because of the inflammation and the infection, na-detach na yung pagkatahi niya. Kaya namumove na. And delikado yun kasi pag matanggal yung valve na yan, the patient will die. So, patay agad. So, nakikita namin yan sa 2D echo. Or, sometimes we don't see vegetations, but we see just regurgitation. So, paano naman namin na-differentiate kung infective endocarditis yung cause versus like a valve lang na regurgitation? Kasi pag, let's say, mitral regurgitation lang na hindi because of infective endocarditis, the regurgitation is at the center. Parang sa coaptation ng leaflet, nasa gitna. Pero ang infective endocarditis, dahil binubutas nila yung valve, the regurgitation nasa gitna ng leaflet. So, malalaman mong, okay, infective endocarditis yung cause ng regurgitation. Okay. So, the 5 minor are predisposing risk factors. Malamang meron kayo makukuha sa history, and then fever. And then yung mga vascular phenomena like arterial emboli, o septic pulmonary infarcts, mycotic aneurysm, intracranial hemorrhage, mga conjunctival hemorrhage, or Janeway lesions. Yung Janeway lesions, ito yung mga parang hemorrhage na konti-konti lang, maliliit-liit sa kamay at sa paa. Pag immunologic phenomena naman, you have glomerulonephritis, pwedeng Osler's nose, Roth spots, rheumatoid factor. To be honest, hindi ko rin sila masyadong nakita pa eh. Kaya I'm not experienced to say na, Osler's nose, Roth spots. Kasi hindi ko rin sila nakikita. It's because probably na-start na sila agad ng antibiotic eh. Kaya mas less na natin sila nakikita. Okay? Or, yung nag-positive blood culture but not the common organism seen in infective endocarditis, it will fall on a minor criteria. So again, 2 major or 1 major plus 3 minor or 5 minor. So yung 5 minor, no, na napasok siya. Anyway, so you need to do an echo because it's parang one of the major pag mapositive na siya. And most likely, if there's infective endocarditis, makikita mo siya sa 2D echo. Kahit negative yung blood culture mo siya, there is something you can see on 2D echo. Okay? So ito yung nakikita namin sa 2D echo on your left is normal mitral valve. Malinis, di ba? Pero tingnan nyo sa kapila, merong mass na nag-o-oscillate. So during systole, nandun siya sa left atrium. During diastole, sumasama siya sa flow papuntang LV, pero hindi siya nadidetach kasi naka-attach nga siya sa valve. So this is an indication na vegetation siya. Kasi ang thrombus, nandito siya nanditong left atrial appendage sa lateral. So galing siya doon, tapos pupunta siya dito, pabalik siya doon, tapos pupunta siya dito. Pag naman, myxoma, attached sa sa septum, interatrial septum. So, mayroon kang indications that help you identify if that mass is a vegetation versus a tumor or a thrombus. Okay, pag tumor sa valve, commonly nasa left ventricular side siya, dito. Hindi doon sa left atrium. Ito kasi nasa left atrial, attached to the valve but on the left atrial side. And it oscillates to the ventricular side during diastole. Opposite siya pag mass, meaning it is attached to the left ventricle during diastole, and then during systole, pwede lang siyang sumilip konti. But most time, it will be on the LV side. Okay. So you need to do blood count, creatinine, liver function test, X-ray, ECG. Pwede ka mag-request ng ASR, pero most of the time, hindi na rin ako nag-request ng ganyan kasi sign of inflammation lang siya eh. Then, sometimes, nagka-cardiac catheterization, kung ooperahan, if there, for example, there will be valve replacement, kailangan mag-coronary angiogram kasi baka may coronary artery disease para isabay na bypass plus valve replacement. So, yun lang yung indication ng coronary angiogram. So, you don't need to memorize all of this. Most of the time, we give ceftriaxone and then we add vancomycin. Ako, ang practice ko, sa lahat ng pasyente kong may vegetations, it's always ceftriaxone plus vancomycin. I don't settle for ceftriaxone lang. Kasi matatalino na ngayon ng mga bacteria, yung mga staff matatalino na, hindi na masyadong dumadala sa ceftriaxone. So, I always add vancomycin. So, kung titinan mo sa lahat, most of the time, pag penicillin resistant yan, nandun si vancomycin. I don't like Genta because mas malakas siyang makadamage sa kidney. Penji, sorry ha, parang judgmental na ako sa Penji. Parang feeling ko hindi na siya ganun ka-effective. But of course, pag government, we use Penji. Mas mura kasi siya. So, let's just run through. In all cases, all bacteria, I always use ceftriaxone plus vancomycin. Okay? Clinical issues, pag IV drug user yan, mag-start ka na ng ceftri and vancomycin. Pag merong yung pacemaker site or ICD na infected, start ka na ng ceftri and vancomycin. Pero siguro pag ano lang siya, let's say, nakuha lang niya sa community, hindi naman siya na hospital within 6 months and then admitted because of vegetations, baka you start muna with ceftriaxone. Pag sinasabi mong empiric therapy, wala ka pang blood culture result. So, you start antibiotic. And pag lumabas yung blood culture na resistant siya sa ceftri, edi palitan mo. Most of the time, vancomycin, hindi pa sila resistant to vancomycin. Kaya, I just add ceftriaxone and vancomycin and then I wait for the blood culture. So you can also treat patients as outpatient as long as they are compliant and hindi dadala yung oral. So mag-IV sila sa bahay. So pwede ka namang mag-ano, especially kung meron silang family members na doctor or nurse. Okay, and then you just have to reassess kung meron mga complications, let's say, CREA, kung tumataas yung CREA, or yung mga SGPT, yung mga toxicity of the antibiotic. And then you have to repeat the blood culture 4 to 6 weeks after the completion of the antibiotic because you have to make sure na wala nang, hindi na siya infect. Parang nag-recover na siya fully, yung meaning sterile na yung blood niya. Kasi otherwise, pag positive pa rin, you have to continue antibiotic. Or baka hindi maayos yung pagkakabigay ng antibiotic. Okay, there are indications to do surgery and I think hindi ito lalabas sa board exam among interns or lumalabas lang to sa cardio board exam. So, ang minimemorize ko dyan, if there is congestive heart failure na hindi nadadala sa medications, like nagbigay ka ng diuretic, nagbigay ka na ng nitroglycerin drip, mga ganun, talagang refractory yung congestion, then subject the patient for surgery. To the echo, if we see the vegetation more than 10 centimeter, we advise for surgery. Or if we see farther damage, let's say meron ng abscess formation or the prosthetic valve, nagmumove na siya, parang matatanggal na, then kailangan mo na siyang po-operan. Or let's say the regurgitation is now severe, kahit magbigay ka pa ng diuretic, magkukongest pa rin yung patient. And that's why you advise for surgery. Okay? So these are the complications for infective endocarditis, congestive heart failure, perivalvular infection, uncontrolled infection, endocarditis. Okay. Meaning, ayun, pahala kayo. So pwede ding may splenic abscess, yung mycotic aneurysm, yung sinasabi kong meron na akong isang patient na hemorrhage yung cause, ni-refer sa akin. Pag wala, may vegetation siya. So, ganun. Pag naman, older age, severe comorbid, may mga diabetes, delayed diagnosis, ito yung mga possible cause kung bakit nagkakaroon ng pasyente ng mga adverse event. So, most of the time, toxic ang vegetation. Namamatay sila. Ang taas ng mortality pag infective endocarditis. So when that 3 years pa lang ako in clinical practice, I already have 4 patients with infective endocarditis, lahat namatay. So, ganun kataas ang mortality. So the prognosis is bad. And i-prognosticate mo na sila agad-agad. And these are prophylaxis kasi common yan, i-refer sa'yo ng dentist kung cardio ka or internist. Then you have to give prophylaxis if they have prosthetic heart valves, if merong previous history ng infective endocarditis, or may congenital heart disease na hindi naoperahan, tapos may mga implantable device or cardiac valvulopathy developing after cardiac transplantation. So, paano tayo nagbibigay ng prophylaxis? We give, let's say, amoxicillin, or we can give ampicillin, we can give ceftriaxone, mga 30 minutes or to 1 hour before the dental extraction. Ganun yung prophylaxis. Hindi siya 7 days. For 7 days mo siya ibibigay before mo siya allow na mag-dental extraction. So it's just about 1 hour before the procedure. And oral lang. Kung hindi kaya mag-oral, edi AIV mo. Ganun lang. Yay! We're done! Mas maganda yung questions. So, clinical criteria lang, yung isang pasyente na-admit because of fever, chills, mga ganun ba? Parang septic yung pasyente. And then on history, IV drug user siya. Tapos ang mga tanong yan, which valve is commonly involved? Ito tricuspid valve, mga ganun. Tapos mga common question na, are they methicillin resistant? The answer is yes, mga ganun. Kasi IV drug users sila most of the time. The bacteria, hindi siya, yung mga IV drug users, di ba, ang dami nilang kababalaghang pinaggagawa. And that's why yung bacteria, hindi lang minor. Kailangan mong higher yung antibiotic mo. Let's say you add vancomycin. Kung may mga, let's say, a pacemaker was inserted, ICD was inserted, tas nag-fever, nag-chills, naku, magduda ka na baka infective endocarditis yan. O yung mga pasyenteng na-operahan na merong valve replacement, you check kailan ba siya. Pag less than 2 months yan, naku, alam na namin mga cardio, yung pagkalagay ng surgeon, hindi mahirap yan i-explain sa patient na, ma'am, infected po yung valve, we have to do another surgery. So another 2 million po, ma'am. I'm sorry po, yung 2 million yun na nagastos. I'm sorry. Wala po akong magagawang iba. Sorry lang talaga. Ay, napakahirap i-explain yan. And that's why you really have to be here. Lahat ng staff in the operating room talagang galit. Malalaman mo pag valve replacement, yung mga surgeon, nag-iiba yung attitude. Talagang binabantayan niya lahat.